Facebook, YouTube Live, Bloomfield Hills, Michigan. So as you will see, this is a very interesting case, complete end block, initials SD. This patient had implants from 1985. So this is a 41-year-old set of implants. This is a 61-year-old patient below the muscle silicone. And as you can see, look at this implant right here, that end block, nice and round, completely removed on top of the rib. These are the rib markings right here, as you can see. And this was very tedious, meticulous, entirely removed in end block fashion. If you look at this one, look at how, quote, big, elevated this is compared to this one on the right. So what I'm going to do is, remember, end block, the gold standard. So just the fact that the implants are from 1985, 41-year-old technology. We just did a case earlier from 2009 that was ruptured. So you can only imagine 99.9% chance that this is going to be also ruptured. So as soon as I go in, you will see, looks very thin capsule right here. Very thin, some areas relatively thick right here. And you can see this is inflamed tissue. I do not like how it feels, how it palpates. This might be a focal extracapsular spillage, but I'm going to go ahead and go in from here. This is the part that I was dissecting around, and you can see all the way complete end block. And this is, one has to go in thinking that both of these are ruptured, and as soon as I go in, you will see clearly this is ruptured. The last one was completely disintegrated. This is, and I'm going to go ahead and move this away. This is the excess skin. You can see the scar right in the middle, contouring that was done. And so from 1985, this is like Ronald Reagan era. This is like 2 years before the Challenger disaster. That's like just to kind of keep things in perspective. And you can see much older technology. You can see all of this yellow on the inside. Everything preserved. And you can see, look at this outpouching. And this is that tissue on the side that was also part of the culprit. And so if I remove this, you can see none of this basically remained behind, and you can see it's gonna basically fall off. And I put this on the back of my hand, very like hard, indurated. And what's interesting about this is, look at the way how opaque this implant is. You can see the shell of the implant completely disintegrated right here. Look at this. And so you saw, so this is a very good comparison. Look at the first case that I did, the Facebook Live. That was a gummy bear, and this is basically very similar to that one. So there was nothing gummy about the implant, the first one, and there's nothing gummy about it. So these older implants, newer implants are more or less the same. So there is no such thing as a gummy bear forever. It might be transiently. And look at this yellow color, everything preserved, and this is the whole purpose behind end block. If anyone says you don't have to do end block, this is the video you need to watch, and I think you will convince yourself without any discussion as to what is the better surgery. And you have to always assume that the implants are ruptured. And again, you can see, like right here, look at this, none of this spilled into the chest, and you can see there's it's literally slime. And if you stand here, there's a volatile component to it. Even though I'm wearing a mask, I smell it. So what I'm going to do now is I'm going to go ahead and left side, relatively more contouring. This was capsular contracture, significant, and you can see over here, significant. This is the tissue on the side that I removed. It's like literally a big ball, and it's under a lot of pressure. Dr. Lamar, if you don't mind, can you give me can you open this for me? So what I want to do here is just to be complete, just touching it. This is, I'm going to go ahead and open it over a container, because if there's any fluid, I want to contain it, and I want to send it off to cytology, because it is spongy, and we'll see what it shows on the inside. So here we go. I'm just going to go ahead and put it here. I'm going to send this to pathology as well. So going to go in from here. Remember, this is all what I dissected off. Let's see what it is. You can see, look at the color of this. It's brown yellow, which means it's dusky, it's abnormal. It looks like necrotic. And I'm going to go in from here. You can see how bad this tissue looks right here. All part of the inflammation. Now there are parts of it that are very, very thin, like right here. So this was very tricky, especially the way it was sitting on top of the rib. Let me just show you here. This is a rib imprint right here. A rib imprint, and a lot of inflammation. A lot more on the left than on the right. So I'm going to go ahead and grab this, watch your eyes there. And this is where, look at this fluid. None of this spilled into the chest. Look at this. None of this spilled into the chest. Seen this before many times. And look at the inside. Looks like literally necrotic tissue. Remember, you have to always think BIALCL whenever you have fluid around. So look at this. It looks like a. I'm gonna go ahead and get my hands wet a little bit. So look at the inside. Literally, this is like mud consistency. And none of this spilled into the chest. And you know, what's interesting is you never know what you're going to find. This patient did not have any imaging. And look at this. I'm going to go ahead and literally tease this off. This is a nice patient, very well read. And we thank her for sharing her journey. And look at all of this. We're going to send this all off to cytology, this fluid. I'm just trying to see any masses or anything like that. Remember, this is any time you have fluid around the implant, you're always thinking badness. The other thing I want to show here is, look, if I touch this, it is super thin, like a millimeter thin. Millimeter thin. Super thin. You can feel my finger right here. So some areas relatively very thick, like right here. And I'm going to cut this open because I want to learn from my experience if I'm ever dissecting. Look how thick this looks, this tissue, and all of this tissue is inflamed. So this is why you have to remove everything in the manner as described. So what I'm going to do is I'm just going to go ahead and move this out. Put it right here. Now let's pull this implant out, ruptured, and you can see. I'm going to put it right here. And this is the fluid on the inside. You know, looks like placental contents, if you will, if you want to kind of make an analogy. And the other thing I want to do is we're going to send all of this fluid off. You can see it's ruptured. Look at the way the implant is disintegrated. It's like an albino colored older generation implant. You see the inside of it. Let me see if I can read over here. Now, everything is disintegrated. Look at that. And I just want to go ahead and show you it's a hemorrhagic contents, all contained. Remember, none of this spilled into the chest. Now, I'll tell you, this was a very involved, difficult operation. This is all going to go, and see, it's relatively thick and viscous too. Look at this. Here's your rupture sign. All right, so a lot to learn from this case. Let me go ahead and get a towel. So a lot to learn from this case. Number one, the older implants, even more than 10 years old, even 5 years old. The last year I did a case where the patient had implants from 2021 and she got an explant by me in 2025 and the right one was ruptured in just 4 years. Just the fact that her implant is over 4 decades old, 99.99% chance she's going to be ruptured. Number two, so the surgeon has to always assume, even if it's a 5-year-old set of implants, you have to always assume the implant's ruptured. Anytime you have an end block that's being done, you have to always assume there's fluid around. And from my experience, I can tell from dissecting that there was fluid. We had the basin ready. Anytime you have fluid around, you have to send it to cytology. It is malpractice to not send the fluid off to cytology to rule out that rare BIA-ALCL. So that is extremely important, no matter how thin the capsule. If the fluid is not tested for CD30 analysis, then that's wrong. It has to be tested for that rare lymphoma, breast cancer, anything bad. Number three, end block is the gold standard. There is no other better way of doing not only the right, but the left, especially when you have fluid. You do not have to rush through the surgery. I have one of my patients waiting downstairs, and I will say, it's okay for her to wait, but this surgery has to be done in a pristine manner. Number four, cultures are going to be done of this fluid to know what it is and what it is not, so aerobic, anaerobic, and fungal. Implants will be returned to the patient. Capsules to be sent to pathology so as to rule out that rare BIALCL, CD30 analysis, rule out lymphoma, twilight deep sedation. This is not the time to be doing a lift, and I'll tell you, this patient does not need drains, and this patient does not need that formal lift. And we'll see how this 61-year-old lady with the capsular contraction on the right and the left is going to be very happy aesthetically how she looks. There is a complete, thorough, meticulous way. Yesterday I talked to a nice patient from Brazil, and she did her homework and she had an MRI. Her implants are from 2013. There's fluid around the right implant. And this is exactly how, hopefully with time, if she does decide to come, this is how I am going to reproduce the same. And remember, the surgeon has to always assume that there is fluid inside, within the intercapsular compartment, that their implants are ruptured, that there is badness inside, because we do not want to find out otherwise. 20 years from now, I cannot imagine anyone being more complete, more thorough, and more comprehensive and more detailed than this, because the entire badness has been removed, and the entire badness is going to be checked by cytology, pathology, and microbiology. So there you have it. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan.